Organization estimates that those people who have lower back pain, 90% of them will have, if you have one occurrence in your whole life of low back pain, 90% of the patient population will have, guess what? Reoccurring back pain at some point in their time. Which is why it's super important to give patients tools to help them treat themselves. Mm-hmm. Because if you're statistically likely to have low back pain again, then yes, we should give you some tools. I would honestly say that it's higher, because let's just say you got low back pain, you went to a hospital, and the World Health Organization is reporting on the hospital stuff, but people like myself and the clinic don't do that. We don't report to the World Health Organization, right? So I would say that it's actually going to be higher. Not every chiropractor or physical therapy clinic reports to the World Health Organization. Only major institutions really do.
Right.
So to answer that question, statistically, I could say you're probably going to have a flare-up, but you should not have to live the way you're living and the way you're presenting with your case and the symptoms. Like, if I looked at your MRI and said, man, this person's probably going to have some serious symptoms, I'm looking at you functionally, I'm looking at you neurologically, and I'm looking at you orthopedically, and I'm like, wow, you're functioning pretty darn good.
Cool.
So, I like that.
Me too.
So,
Me too. Right?
if you want, you can have a seat. If not, we're going to go through some more stuff. So,
I'm going to stand.
Okay, that's fine.
I don't like sitting.
That's okay. That probably hurts your back.
Yeah, sitting, just the drive here irritated it. I woke up and I felt pretty good, and then just driving here, it was like, I don't like this.
There's a couple other tests that I could do on you. I don't necessarily think they're as valid anymore because, I mean, like, you just don't present that way, so I don't think we have to do it all.
That's fine.
But we already know that you're getting that disc compression. I wanted to show you a little bit deeper, those concentric rings that we were talking about when we said...
trees, yeah.
Come on.
The layers.
Yes. I don't know why my program's... there we go. Boom. So when we kind of zoom up on the disc, here's those trees and those layers right there. So when you have a break in one of those posterior fissures or layers, you can have that disc bulge out. She's having quite a large disc bulge according to your awesome MRI, but you're not having it clinically because based off of that, you should have nerve pain that goes down. Let's add the nerves.
In my legs.
You should have nerve pain. If I looked at your MRI, you should have the L5S1 nerve root that goes down through here, all the way through to this area, and you should have it underneath your foot all the way through.
Yeah.
Based off of the side of that. Not only do you not have that, but I also tested you clinically with raising your leg up. When we did that straight leg raise, that's for me to pull down on that nerve. When I went across and did this, I'm pulling not only on the tibial portion of that nerve, I'm also pulling on the peroneal or the outside, which is more the L5 nerve root. Mm-hmm. I also did the L4 on the inside.
Yeah.
You had more symptoms, surprisingly, of L5. That's why I stopped and made a quick note. I was like, holy crap, this person's actually presenting slightly different. Yeah. So if I had to guess, how are you presenting? You're actually presenting with more symptoms based off of the lesser disc bulge than you had the greater one.
Interesting.
But that doesn't mean, statistically speaking, according to research at this point in time, those patients who have more than one disc bulge are more than likely to have more symptoms. Shocker. You have more pain, you have more inflammation.
Yeah.
That's actually what seems to be the driving force between people who have symptoms and not. It's not necessarily do you have it, do I have it. It's what lit you up to create that. What created, there's always somewhat gasoline around. Mm-hmm. What created the spark? What created that inflammation? You know, is it stress? That's why I ask these questions. High stress? Are you being nice to your body? Are you falling from airplanes? What's happening?
Yeah.
You know, things like that.
I haven't jumped in a while. A really long time, actually.
But I think that might have been
it's been over a year.
It seems like that was one of the major onsets for this. So what you did is you just did this.
Well, you don't actually, like, fall and, like, I haven't had a bad landing in over 7 years because once you get better, I have over 300 jumps. That was like,
jeez.
That was like in the very beginning of my skydiving days, and the winds were weird, and my canopy collapsed. That's not something you experience. My landings are typically really soft. I typically just tiptoe in, and I'm
You're solo, huh?
Yeah.
No, maybe one day. Maybe one day when I don't have a wife.
Yeah.
But
twice in one day. That's my recommendation.
That's all right. I already did one. I'm good. So any questions on that so far?
No.
I think, when I was testing your hip flexor, you had a little bit more tightness through here for sure because you got like a little bit more stuck. And
on the right side?
I was able to open that up. Surprisingly, I think you have a little bit lesser glute development on the left because when I lifted your hip up, you saw the other side kind of like curling and compensating. Whereas the right side, you actually had good glute control.
Mm-hmm.
So I think if we can get that a little bit stronger, a little symmetrical, I think that'll be a little bit better. The question would be is like, what are we doing that makes it feel better? What are we doing that makes it feel worse? Where do we start with you? I think we might have to start at a slightly higher advanced stuff because one, she knows a lot more information than most patients dealing with this stuff. She's done a lot more treatment like DNS, which is advanced type work. But at the same time, like, what else are we doing that helps you or hurts you?
Right. I don't like sitting. That's what I can tell you.
No, and you do have a reduced flexion and you have improved extension. So the big key thing that we notice in most disc patients, this is 90% of about disc patients, maybe 85 to 90% of disc patients. When we bend forward, we have that bulge that goes back where you have this naturally. But when we bend forward, we do that to it, right? So what we do is when we do those extensions out there, we're actually doing this. We're squeezing the back and we're helping to reabsorb
These back ones like this?
When I had the press
ups. Oh, okay, yeah.
So that's what I think you sitting there and holding that for like X amount of minutes is probably too aggressive, too much extension. So I need you to do more repetitions. Just like you doing repetitions to build a bicep or a muscle, you need to do more repetitions to help decompress the disc a little bit back there and get some mobility because going forward seems to increase your symptoms a little bit at this point. Not entirely. Most of the time it's like, So I think we need to get in there.
Yeah, you should see me doing yard work and pulling weeds. I'm basically like on my hands and knees so that I don't have to bend over. I'm just like crawling.
So we call that flexion intolerant low back pain, meaning you can't bend forward without back pain. That's what we call it.
Yeah, but I've gotten really good at like, picking things up because now I'm like literally like.
So she's highly functional. I wish I gotta bring you in for another patient who's literally not functional when I first see them. Like you should see the difference. I wish you could see it, but I'm glad you can't see it because
I don't want to see it. I'm really glad I don't see it.
No, I'm glad.
I mean, I'm also like from where I was, I would say like from 3 weeks ago is way better than where I was 3 weeks ago.
In my opinion, as a chiropractor myself, I do a lot of manual therapy. I do a lot of rehab advice. I do a lot of give you tools at home that help you. But at the same time, I want you to have a plan, and I want you to be able to like digest it properly. Mm-hmm. And so I think it's really about like exploring what you're capable of, what you're not capable of. And I personally just don't love adjustments entirely for both sides.
Yeah.
Discs that are protruding do not like to be torqued very aggressively. You probably
the wrenching that's
they do not like to be that initially.
What's been so surprising is that like both the guy that's down in Eastlake and the guy that's the DNS guy, both of them do the wrenching where they turn you to your side and go.
Listen, as a chiropractor...
I mean, I feel good after I leave, so I don't question it, but I'm like, this is kind of aggressive. I feel like this is
a chiropractor myself who adjusts patients daily, every damn day, I would be hesitant to adjust you at all, and if I did adjust you at all, it would be light, and if I did adjust you lightly on one side, or even aggressively, it would be on the upside or the right side. Mm-hmm. I would not be doing the other side because what we're doing is when we do this, we gap that, which is what we want to do. We want to open up the space so that this has more breathing room, so to speak, or the neural foramen is not as compressed. But the other side, if we go downside, we're opening up this side, but we're compressing this side. Mm-hmm. So what makes me think that I should adjust the left side for fun? Like, I'm not here to have, you're not here to be experimented on and have fun with.
Thanks.
I personally... If we did adjustments, great, fine. I would only do the right side today. And yes, we could do your mid-back and stuff like that and all that other stuff. But I would not be doing the left side of your low back.
Yeah, I'd say the interesting part though is that the pinching feeling transfers from right to left. So like one day I'll feel more pinchy and compressed on the left side, and then the next day I feel more compressed and pinchy on the right side.
So she's got bilateral compression, which both sides go down, so that's probably why.
Yeah.
But I personally would just try to open up the nerve hole where the nerve is coming out, and if we have a 3 centimeter, I don't want to call it centimeters, but you know, because it might be wrong, 3 to 9 millimeter or a 3 to 9 centimeter, whatever you want to call it up there, however they measured it. You have compression. We want to open that compression up so that it can finally self-absorb and decompress through that spine. What you normally have to focus on, and what most patients do, is they try to do core-based exercises. I have no problem with core-based exercises, DNS and all that other stuff, but if you notice, DNS is actually a little bit different. You get your hips involved. You do a lot of that stuff. The way you really fix low back pain, generally speaking, is not by fixing the spine and getting your back strong or your belly tight. It's about getting the pelvis and the hips mobile and strong.
Yeah.
Because this is the foundation. It's like having a crappy foundation and building a tower on top of it. Like, these are our little tower blocks. And if this starts to work too hard or not doing what it needs to do, all these areas are going to compensate and overload at some point in time. That's why you see a lot of people like pull out their back and like, oh, I hurt myself deadlifting. I'm like, well, that's because your hip mobility sucks and your power sucks and you use your spine. Mm-hmm. The spine's not meant for that.
So I don't know if you can tell me what this is, but I've had this for like a really long time, but when I lift my left leg and bring it back down, something is like clicking in there.
In the back?
I don't know if it's in the back. It kind of feels like it's, maybe, I don't know. It feels like it's in there. I mean, it's pretty prominent. Like if you, sometimes you can hear it. Like if you didn't have the music on, you could hear it. It sounds like something is like.
Is it, you feel it through here?
I don't feel it in here. I don't even know where
so
it is. It feels deep. Like it feels so deep that it doesn't feel like something that I could be like, it's this. I mean.
One of the biggest symptoms that you said to me that are extremely common is that a lot of patients will have psoas or hip flexor pain as a result of that, which is right here.
Yeah.
And you immediately said that when I did too much, I felt it. You know, I believe that if we reduce the tension and strain on your hip flexor or iliopsoas area, which we will do today, we can really alleviate a lot of your pain because the hip flexors are powerful. They need to be mobile, they need to be powerful, but they also attach to the spine. So if your spine is like irritated or pissed off or you did something wrong to it, you're gonna have the hip flexor seize up around it.
Yeah, so something that I experience when I'm in child's pose or if I'm doing a hip flexor stretch, which is one of these guys.
Yep.
So when I get down and I do this and I get in there, the back, I can feel something from the back of this knee all the way up into here. And so it almost feels like something's not rotating right. Like, I don't know, it's from the back of the knee up. It's definitely like digressed a lot since I've been doing a lot of different types of stretching, but
I think that's going to be the hardest part of your case. Is not that you're advanced, it's just that you have a lot of different therapies that she's educated on. So it's like, what route do we take? And here's my route. It would be, normally I believe in less is more. Let's just have you do 3 of your favorite exercises, or maybe 1 exercise that I recommend plus your 3 that you know help you, and then we stick with that, as opposed to saying, well, let's do 25 exercises and see what works.
Yeah.
Because then we don't know what if 5 exexercises helped you? You wasted yourself with 20 exercises then.
Yeah. I also don't have that many hours in a day.
No,
once I go back
no, we don't. No, we don't. So I think the first thing we'll do is we'll try to relieve a lot of the hip flexor tension on both sides.
Okay.
We'll try to give you some manual traction. We'll probably work some of the spinal musculature. I think we could do a little bit more advanced stuff with her, because normally on the first visit with patients who have sciatica, I do not mess around at all with their hamstring, period. Not for several visits.
Yeah.
Not until their symptoms are at least like 40 to 60% gone, maybe even 80% gone.
And what's the reasoning for that?
Because when you pull down on a pissed off, irritated nerve, when you pull it down, it gets more pissed off and irritated. However, your symptoms didn't present that way.
Yeah.
So I think we can take that risk and because the risk reward ratio is not high in terms of risk.
Yeah.
Value.
I feel like getting some of my inflammation down as well has